All right. So, good afternoon, everybody. I would start with the introduction to the named lectureship today, the Robert Myberg lecture, Grand Rounds at the Department of Medicine. A few words about Dr. Myberg, who is among the many generous individual donors, colleagues who feel the responsibility to contribute and pay back to the society and the academic society here at the University of Miami to help us advance our mission, which is excellent care, top-class research, and of course, education. So among those generous individuals, Dr. Myberg is definitely a great paradigm. He started his journey in life from Baltimore, his training in great institutes in the primarily Southeast, from Baltimore to Miami, then to Tulane, New Orleans, New York at the end. And then he was appointed as assistant professor in the 70s at the University of Miami, where he escalated the ranks, and he finally became the longest chief of cardiology in the history of the country. A real academician and physician scientist. He shaped the field of electrophysiology through his research and rigorous teaching all those years. He has contributed to major textbooks in the field, and he is definitely the father and behind all the successes that we have indulged all those years in electrophysiology. He's still very active, active clinically, active as a teacher and educator, and we're blessed to have him around. Without further ado, I'm going to pass it to our chief resident to introduce our distinguished speaker today, Dr. Sinusas, who is the perfect paradigm of a physician scientist academician who definitely reflects the value and the greatness of this named lectureships. Thank you so much.
Thank you, Dr. Chassis. It is my pleasure to introduce Dr. Albert Sinusas as the speaker for today's Grand Rounds. Dr. Sinusas received his MD degree from the University of Vermont College of Medicine and completed his residency training at the University of Oklahoma Health Sciences Center. He then completed his cardiology fellowship training at the University of Virginia Health Sciences Center, and he's currently a professor of medicine, radiology, and biomedical imaging and engineering at the Yale University School of Medicine. At Yale, he serves as the Director of Advanced Cardiovascular Imaging, as Director of the Yale Translational Research Imaging Center, and as the Radioactive Drug Research Committee Head and Radiation Safety Committee. Dr. Sinusas is also one of the national leaders in cardiovascular molecular imaging as well. He served on the board of directors for the American Society of Nuclear Cardiology and the Cardiovascular Council for Society of Nuclear Medicine and Molecular Imaging. In 2018, he chaired the NIH Medical Imaging Study Section, and the following year, in 2019, the NIH Clinical Translation and Imaging Science Study Section as well. He's board certified in medicine, cardiology, nuclear cardiology, and cardiac CT. His research is primarily directed at the development, validation, and application of non-invasive multimodality and molecular imaging approaches for the assessment of a wide range of cardiovascular diseases, employing from SPECT-CT, PET-CT, X-ray, CT, fluoroscopy, and cone beam CT, echocardiography, and MRI imaging. He serves as the PI on multiple R1 grants and co-investigator in several other NIH grants that involved multimodality imaging in animals and also patients, and co-directs a T32 grant for training in multimodality molecular and translational cardiovascular imaging. Today, he will be speaking on the topic of the emerging role of imaging in cardiovascular theranostics. Thank you so much for joining us today, Dr. Sinusas.
All right, thank you for the introduction. And this is my current funding, and I do need to disclose some relationships with industry and consulting for Microvid, which is a startup company that's trying to move forward targeted MMP imaging to first in human. So in the tradition of medical grand rounds, I wanted to start with a case. And so I present a 48-year-old male who has a past history of uncontrolled hypertension, newly diagnosed diabetes, chronic back pain, who had a prior extensive cardiac workup back in 2021 for chest pain, and that was negative and found to have normal left ventricular function. He presented actually in January of this year at our Bridgeport Hospital with on and off back pain and substernal chest pain over the course of a week. When he was admitted to the hospital, the concern was for a aortic dissection, so that was ruled out with a CTA. And then based on ECGs, he was transferred to the cath lab for evaluation and treatment, which was an acute anterior ST elevation MI. Due to sort of a complicated course, he was then transferred to the main campus here in New Haven, at which time he had dramatic ST changes and remained relatively hemodynamic stable. He had serial echocardiograms and right heart cath and MRI, and I'll kind of show some of that. So his initial EKGs when he presented 3 in the morning are shown here. He had initial elevated high sensitivity troponin T, markedly elevated glucose, elevated hemoglobin A1C, as well as an increase in lactate. And then shortly thereafter, he manifested an EKG consistent with an evolving anterior septal MI. So as one would expect, he went to the cath lab and was shown to have a total occlusion of the proximal LAD. So we're looking at the circumflex and the LAD, which is sort of Trump occluded here at its origin. They attempted to revascularize that LAD and open that up, but there was severe no reflow, and patency was sort of refractory to pharmacological therapies, aspiration, thrombectomy, and he ended up with what was considered TIMI-1 flow down the LAD. They deferred stenting due to the poor outflow and evidence of this no reflow phenomenon. And so he was initiated and infused with a 2B3A inhibitor. Initial echocardiography showed a large wall motion abnormality in the anterior apical region. There was a suspicion for a clot. He subsequently underwent MRI, and you can see that there is a large, on these cine-MR images, a large wall motion abnormality here. There appears to be areas on the initial scans of hypoperfusion, suggesting microvascular obstruction. And then late gadolinium imaging was performed and demonstrated hyperenhancement, as well as this evidence of microvascular obstruction, as well as the layered sort of thrombus in the anterior apical wall. So, you know, this is a gentleman who appears to have presented somewhat late, has complicated MI, and is likely to end up in developing LV remodeling and heart failure. So during my talk, I'm going to provide an overview of molecular imaging, talk a little about the pathophysiology of post-MI remodeling, the important role of matrix metalloproteinases, integrins, and fibroblast activation protein, talk about the use of targeted molecular imaging post-MI, the potential for MMP inhibition, potential role for a therapeutic delivery of hydrogels into the heart, briefly review some of the pilot human studies involving therapeutic hydrogels, and our work in developing an imageable theranostic hydrogel to prevent post-MI remodeling, and the role of multimodality imaging and the potential future for image-guided interventions. So, as you know, with atherosclerosis, there may be plaque rupture that leads to ischemia in the myocardium, and depending on the duration of ischemia, that can lead to myocardial infarction, and depending on the size of the infarct, one can end up with post-infarct remodeling. And traditionally, we evaluate anatomic structures and or coronary physiology and myocardial physiology, but there are a lot of processes that are going on, which include inflammation, thrombosis, apoptosis, necrosis, fibrosis, and then the angiogenic response and the arteriogenic response in order to sort of compensate for the hypoxia associated with the ischemic injury. And the role of molecular imaging is to really detect these processes at an early stage prior to manifestation as anatomic changes or physiologic changes. So in the setting of acute myocardial infarction, there are multiple phases or stages. The first is an inflammatory phase where there is the influx of inflammatory cells, the release of inflammatory cytokines, and then that progresses into a proliferative phase in which there is transformation of myofibroblasts, there's an initiation of an angiogenic response, and then in the later stages, there's more of a remodeling phase, which involves an active role of myofibroblasts in restructuring the extracellular matrix and sort of removing cellular debris. So as I sort of discussed, the remodeling is a complicated process. It starts with inflammation. There's a release of pro-inflammatory cytokines. There's activation of MMP.